So the next talk is sticking out for quantifying ocular displacement by Dr. Sija, uh, working in Alapi Medical College as professor.
Thank you, KSOS, for this opportunity. So next is sticking out, quantifying ocular displacement. The volume of the orbit is small and it is confined by bony walls on all three sides. And it has numerous structures serving both ocular and extraocular functions like the globe, muscles, nerves, and blood vessels. A proper evaluation of the orbit is very important because it gives insight into the disease process, helps us in evaluating the imaging techniques and arriving at a correct diagnosis. First and foremost, the most important thing is that orbit is like an abdominal cavity. It is very difficult to visualize the structures inside, and so a proper history is very important. We have to stress about the history many times. The common presenting complaints usually include pain, proptosis, defective vision, diplopia, and even some mass. So a detailed history should be taken. Then systemic and general examination is also very important, taking into consideration the thyroid, then ENT, skin, all the details should be taken. And full ophthalmic evaluation includes all the routine plus RAPD, pupil, color vision. Examination of the orbit consists of inspection, palpation, measurements, and auscultation. So I'll go directly to the measurement part, which is our topic. So as soon as a patient enters our OPD, before going for the ruler or the exophthalmometry, quick clinical assessment can be made. If you are sitting in front of the patient, we can ask the patient to tilt the head backwards and then look from below upwards. So especially in a unilateral case, it is easy to identify the proptost eye. This is known as the worm's eye view. Then we can go behind the patient, stand behind the patient, ask the patient to look straight ahead, just tilt the head backwards and look tangentially over the forehead. Here also we can see that the proptost eye can be easily made out. If we don't have any other special equipment with us, even with the ruler we can start measuring. So ruler is kept at the lateral orbital margin, and distance from that to the apex of the orbit should be taken, but make sure that it is parallel. Exophthalmometry or proper is the measurement of proptosis. The reference points usually taken are the lateral orbital rim and the apex of the cornea. The generally accepted normal value is between 14 to 21 millimeter. The absolute value is less important than the difference between the two eyes. The difference should not differ by more than 2 millimeter. And you have to measure in all three directions: anteroposterior, horizontal, and vertical. The one we use in our OPD commonly is Hertel's exophthalmometer. It is used for axial proptosis. It has less inter-observer variation. It has two foot plates. One is fixed and the other sliding on a scale. And the scale has a marking, reading below. That gives a base reading. So each plate has a viewing mechanism, usually a mirror or sometimes with a prism, and a scale reading is given below the mirror. And it helps in serial follow-up of the patients. The patient and examiner should be at the same level. That is very important. We have to sit in front of the patient, or if the patient is standing, we have to be at the same eye level. And rest the fixed plate on the right orbital margin, lateral orbital margin. Once it is fixed, slightly slide the other one to the left orbital margin. And now note the distance between the two foot plates. That gives the base reading. And this is necessary to compare the results over a period of time. Next time when the patient comes for follow-up, we have to keep the base reading as constant and then start looking at the proptosis. And once the base reading is taken, now we have to tilt our head or adjust our eyesight. Then we will see two lines on the mirror. Adjust our head and make it as a single line. And once that is aligned, now go for the corneal apex reflex. This helps us in avoiding parallax error. Now the reflection of the cornea in the mirror is taken. That gives the value. And this is how it is notated. So we'll see an example. So first, as we are in the same level of the patient, keep it on the one side, slightly slide. You should not apply too much pressure also. It will be painful for the patient. And once the base reading is taken, it's about 101 here. Now look at the mirror and adjust the two markings as a single line. and the reflection on the cornea. Similarly for the other eye. Next equipment used is the lewd scale. It's a transparent ruler thicker than the normal ruler with a notch. This notch conforms to the lateral orbital rim. It is lightweight and cheaper than the Hertel's option. So here the scale reading is from 0 to 40 millimeter. And the scale starts from the tip of the notch where it meets the orbital rim. That is the advantage comparing to the normal ruler. There will be a gap in the normal ruler when we keep at the lateral orbital margin. So the reading may be not accurate. But here reading starts from the notch. And it avoids parallax error because scales are there on either side. And it is better than Hertel's in case of facial asymmetry. The other one is the Nagel's exophthalmometer. It is here the frontal and maxillary bones are taken as a reference point and gives better patient comfort and cooperation. It's especially useful in cases with facial asymmetry and trauma patients where the lateral orbital margin will be disrupted. It gives better precision and reproducibility. Another one is the Moritz exophthalmometer, which consists of prisms and it is said to be parallax free. But the sources of errors commonly in these exophthalmometers are the patient if not cooperative, not looking straight ahead, then parallax error, and if the crossbars are not parallel to the floor. Non-axial proptosis or dystopia, here it is a horizontal or vertical displacement in the coronal plane, which may or may not coexist with forward displacement. To measure that, we need two rulers. For the vertical displacement, first ruler is kept at the level of the lateral canthi and second ruler is placed in front of the first ruler, and the distance from the scale to the 6 o'clock limbus is taken in both eyes. But in case of dystopia, it may be difficult to get the patient to look straight ahead, so we have to occlude one eye and the examining eye ask them to take up fixation. For horizontal displacement, put a mark on the center of the nose and place a ruler there. And the distance from this mark to the nasal limbus is taken as the value. The difference between the two readings give you the horizontal displacement. This one I went through the research and got, it's a McCoy tri-square. It has a stencil-like equipment with all the markings and a gap for the nose. So it is easy to have the horizontal reading, vertical reading, everything. How to measure proptosis on a CT scan. It is known as Hilal and Trokel method. Here we have to locate first select the CT slice which we need to have the measurement. It's a mid-axial CT slice, meaning it is a cross section through the middle of the orbit and that bisects the lens. That cross section is taken. Now draw the reference line. It's a straight line connecting the tip of the orbital rim or the interzygomatic line. So this yellow dotted line is the reference line. And from that reference line, two vertical lines are drawn towards the apex of the cornea or the anterior-most part of the cornea. And this gives the value. If it is more than 21 millimeter on either side or if it is more than 2 millimeter difference, it is significant. So once we are done with the measurements, we have to go for the other tests like finger insinuation, resistance to retropulsion. Then look, and in some cases like varices, the values we have to take twice. First do all the values, then ask the patient to look forward, bend forward or do Valsalva, and we can repeat the values so that we can know whether the proptosis is increasing. So concluding, proptometry helps to assess and monitor the orbital diseases and helps to distinguish pseudo from true proptosis. And when combined with other clinical techniques, it helps facilitate a comprehensive evaluation of orbital diseases. Thank you.
So thank you, Dr. Sija, for elaborating how measurement of doses